acetylcholine activity at muscarinic receptors in the striatum. This pathway gives you a magnified version of the beginning of the indirect pathway in the basal ganglia. You may want to go and review direct and indirect pathways, by the way, in your neuroanatomy. Here you see the GABAergic neuron from the striatum, particularly from the actual caudate putamen, as it's on its way towards the globus pallidus. This GABA neuron, which is inhibitory, like all GABA neuron, is under the control of two receptors, D2A, which is GI coupled, and therefore which is inhibitory, and a muscarinic such as M3 receptors, which are GQ coupled, and therefore excitatory. The control, therefore, comes from the presence of dopamine from the nigrostriatal pathway, shutting down the GABA neuron through D2A stimulation, and the acetylcholine neuron from a local the neuron in the indirect pathway, exciting the GABA neuron and maximizing the inhibition downstream. Neuron from a local interneuron in the indirect pathway, exciting the GABA neuron and maximizing the inhibition downstream. Well, it is that inhibition of an inhibitor which results in distorting of movement. So you start the movement in the indirect pathway through dopamine inhibiting the indirect pathway. Conversely, acetylcholine is trying to prevent that movement initiation by overstimulating this GABA neuron through muscarinic receptors. The numbers then represent the potential groups of drugs used on that system. The primary drug we will review is levodopa. L-dopa is a precursor of dopamine that will cross the blood-brain barrier and whose job is to increase in the patient's brain the dopamine production. Otherwise, at position 2, dopamine receptor agonists could be used to stimulate the D2A and shut down the GABA neuron, or indirectly, chemicals like selegiline would inhibit MAOB and result in an increased dopamine remaining inside the neuron, so preventing its breakdown is another approach. Finally, but differently, the use of muscarinic antagonist will try and temper the imbalance whereby acetylcholine is too strongly stimulating that GABA neuron. Overall, the dopamine drugs are the ones we really need to review right now, since we have already seen anti-muscarinic drug when we reviewed atropine. Let's then review the drugs that increase dopamine function. Levodopa being the primary drug in the treatment of Parkinson's disease, it's certainly the central aspect of your treatment. Levodopa, first and foremost, is a prodrug. It is converted to dopamine by the enzyme aromatic amino acid decarboxylase, also known as AAAD. AAAD is found both in the central nervous system and in the periphery. And because of the fact that dopamine does not cross the blood-brain barrier, we do not want levodopa to be metabolized in the periphery of the patient. So levodopa is always given. You can cross out the word usually in your book and replace it by always. It is actually mixed up with the drug levodopa in the same pill. It is always given with a chemical carbidopa. And carbidopa is actually a peripheral inhibitor of the AAAD. As a peripheral inhibitor of AAAD, it has a little point that might cause you a little exam question with graphics, again, from biochemistry. This is not a competitive, but a non-competitive inhibitor. And as a non-competitive inhibitor, you know, this is a chemical that would therefore decrease the Vmax of the enzyme AAAD. So, irreversible peripheral inhibitor of AAAD, carbidopa, is added to levodopa. We'll look at this in a big diagram to summarize all these drugs afterwards. Needless to say that levodopa's purpose is to make dopamine in your brain. And when you have high dopamine, it'll be pretty impossible to try and mimic the physiology of a nerve terminal, releasing dopamine on the right cues when you want to start the actual movement cascade. As such, when levodopa becomes dopamine in your CNS, you will see dyskinesias as a limiting side effect. Those dyskinesias are going to be often referred to as the on-off phenomenon or on-off effects. Basically, when there is high dopamine, you can imagine that movement cascades will be started, and it will be as if you were turned on, as if you had given a drug that would just press a switch on this patient, and now the patient is uncontrollably starting movement. Every time dopamine drops, simply because you metabolize and clear the drug, then the patient will be turned off, reverting back to his or her pathology of Parkinson's disease with bradykinesia. So these on-off effects, to try and minimize them, we need to minimize the fluctuations in dopamine. So there's no major increase all of a sudden and major decrease quite rapidly afterwards. And to do this, we're going to use levodopa in conjunction with many other drugs to try and maintain a fairly steady level of dopamine in the brain of a patient. Otherwise, as you increase dopamine in the brain, some of that dopamine will be made in the mesolimbic, mesocortical pathway. As such, the risk of psychosis, hallucination, schizophrenia type of responses are very much part of the side effects of the medication levodopa. In the periphery, levodopa has a precursor of dopamine to bind to D1 receptors. Let's not forget that our D1 receptors in the periphery, as we saw in the autonomic nervous system section, would be associated with vasodilation. And with this vasodilation, hypotension would become a side effect. Hypotension is always a worry in geriatrics, being that following hypotension, reflex arrhythmias could occur. And if other possibilities, we know that dopamine in the CNS can bind to D2 with a characteristic chemically as a precursor of dopamine to bind to D1 receptors. Let's not forget that our D1 receptors in the periphery, as we saw in the autonomic nervous system section, would be associated with vasodilation. And with this vasodilation, hypotension would become a side effect. Hypotension is always a worry in geriatrics, being that following hypotension, reflex arrhythmias could occur, and if anything, hypotension can make someone feel very dizzy. An older person feeling dizzy could fall. Falling could result in the breaking of a bone. Breaking a bone, if you're an elderly, could be associated with significant morbidity, simply because of osteoporosis. Other possibilities. We know that dopamine in the CNS can bind to D2 receptors in the chemoreceptor trigger zone and result in significant vomiting. So vomiting, nausea are also classic side effect of a medication, levodopa. Although I doubt your exam would really make a big fuss about it, but just in case on step 1, could you actually tell me what you expect levodopa would do to prolactin? If you're answering it should actually decrease levels of prolactin in the patient, you are absolutely correct. Let's recall that dopamine is prolactin inhibiting factor. So many other drugs will be used together with levodopa, carbidopa combinations in order to maximize the efficacy of the treatment. Past the little diagram at the top of your page for right now, we'll go back to it in a second, and let's look at least 2 other groups of drugs. First, the group of the capone drug. No alcapone here, but tolcapone and tacapone. These are drugs that will actually inhibit COMT. What is COMT? COMT stands C for catechol, which is the structure that is common to these neurotransmitters such as dopamine, norepinephrine, or the hormone epinephrine. The O is for oxygen, O. M for methyl, and T for transferase. So this is an enzyme that transfers a methyl group on the oxygen of a catechol ring. Whatever it does, it metabolizes compounds such as dopamine, norepinephrine, epinephrine, and also levodopa. COMT will actually convert this chemical to their 3-O-methyl metabolite. For instance, levodopa . levodopa would be the one that would become 3-O-methyl-dopa. Dopamine would become 3-O-methyl-dopamine. It doesn't really matter. The idea is that these methylated compounds behave as partial agonists. And partial agonists at dopamine receptors can behave as antagonists in presence of high dopamine. So the worry would be for the levodopa to become the partial agonist, and then the partial agonist compete with dopamine and decrease both the uptake of the drug and the efficacy of the drug in the brain of a patient. Well, we need to know really the mechanism of action of tolcapone and tacopone as a family, the reason why we use them to try and prevent that partial agonist formation. And if you want to be perfect, you may want to know that like so many CNS drugs, since they're lipid soluble, they require high liver metabolism, and tolcapone is actually fairly hepatotoxic. Another drug that will be used is the drug selegiline. Selegiline has always been a key point on board question, primarily because it is the selective monoamine oxidase B inhibitor. And because it blocks selectively MAO-B, it will be associated with no tyramine interactions. That is, if you recall, no cheese effect, no hypertensive crises. Why would that be, that there are no hypertensive crises with selegiline? I know you're saying, well, because it's selective MAO-B, but what I want you to remind me here is, what is the story behind tyramine? You remember that tyramine is normally metabolized by MAO-A, just like norepinephrine and serotonin would be. So the idea is that this selectivity for MAO-B cannot result in increased levels of tyramine or norepinephrine, and therefore no hypertensive crisis. Well, remember this well, because that has been a board point forever, literally. It is used initially in the management of Parkinson's disease and generally as an adjunct to levodopa to allow the dopamine not to be metabolized in the brain of the patient. Just like all dopamine drug, it's primarily side effects are dyskinesia and psychosis. Dyskinesia from increasing dopamine in nigrostriatal pathway, psychosis from increasing dopamine in the mesolimbic tract. What's the deal with the insomnia, then? Well, this is a different story, and as a different story, it also bears relevance to a board question out there. Selegiline is metabolized to amphetamine. And in its metabolism to an amphetamine, you can imagine it gets metabolized to a psychostimulant. Psychostimulants are notorious for getting you agitated, and this agitation will classically result in insomnia in the patient. They can become anxious also and restless because of this amphetamine. Finally, never forget that if a drug is metabolized to an amphetamine, what if this patient of yours wanted to apply for a job, for a position, and then had to undergo a drug screen? Well, guess what would happen? This patient on selegiline for Parkinson's would screen positive for amphetamine use and be thought of as a potential drug abuser. So you may actually be called upon to tell a judge or law enforcement officials that no, this is a patient and it is your selegiline that is the most likely reason for those positive amphetamine in urines of that patient or in the blood of that patient. Now let's look at this big diagram. As we look at this big diagram, we are summarizing here what we achieve by combining all these drugs in the management of Parkinson's disease. Here is the blood-brain barrier, And as you look at the blood-brain barrier, you see the periphery at the bottom, the CNS at the top. So the diagram really represents someone standing, if you wish. Levodopa is your primary drug. Levodopa, you want it to go across the blood-brain barrier and be found only in the CNS. Therefore, metabolism of levodopa in the periphery at all costs must be blocked. This is achieved primarily by the blockade of AAAD by the chemical carbidopa. Let's not forget it's an irreversible inhibitor of the peripheral AAAD. That prevents the formation of dopamine, which would not be able to cross the blood-brain barrier. But then let's not forget we must also add the COMT inhibitors, and we add COMT inhibitors such as tolcapone or entacapone, the capone-like drug, to prevent the formation of 3-O-methyl-dopa, which would behave as a partial agonist and at this point compete with levodopa for uptake across the blood-brain barrier. So if I have all these drugs together, there's only one possibility, which is for my levodopa to now go across the blood-brain barrier and get into the CNS of a patient. It is critical then to remember that the AAAD in the brain of this patient is not inhibited by carbidopa, or essentially that the word peripheral in front of inhibitor for carbidopa is a critical word, meaning carbidopa itself must not cross the blood-brain barrier, such as levodopa would now become dopamine in the brain. How about for the COMT? Should I block COMT in the CNS? Of course we should, because otherwise in the CNS we would form that 3-O-methyl-dopa, which would now compete with dopamine for binding to receptors and behave as a blocker because it's a partial agonist. So unlike AAAD, COMT inhibition must occur both in the CNS and in the periphery. What is the third drug I could add to this cocktail? Well, the third drug I could add to this cocktail would have to be selegiline, the MAOB selective inhibitor. With selegiline, now I prevent the breaking down of dopamine to inactive metabolite. Well, if you really do all this, then there is no doubt the only thing that is going to be left for your drug to do is be levodopa in the periphery, go into the CNS, stay levodopa in the brain, AAAD makes it dopamine, and then nothing else happens. You've maximized the efficacy of your treatment. Are these the only drugs used in Parkinson's disease? Well, not really. We know we could use also dopamine receptor agonists. And to use dopamine receptor agonists, we have some full agonists such as bromocriptine, such as also pergolide. And bromocriptine and pergolide are some of the oldest prototypes of dopamine receptor agonists. Problem with agonist is always the same one in pharmacology. These are drugs that have efficacy. And with efficacy, it means potentially overstimulation of receptors and excessive responses. Well, for sure, the side effects of dyskinesias and psychosis are really enormous with those two drugs. As such, bromocriptine and pergolide are really not used in Parkinson's disease. They're primarily used acutely to manage hyperprolactinemia, maybe postpartum or maybe secondary to a pituitary adenoma producing prolactin, and also used in acromegaly gigantism to suppress the GH secretion. There are other dopamine agonists that are less potent than those old drugs, bromocriptine and pergolide, and these other dopamine agonists are used in Parkinson's disease. When they're used in Parkinson's disease, they also have an advantage. We're talking here about pramipexole and ropinirole. You see, these two drugs are also antioxidants. Let's not lose track of the fact that when we think of an etiology for Parkinson's disease, we tend to emphasize oxidative stress, free radical damage to dopaminergic neurons. As such, antioxidants seem to be a good idea, maybe actually for once not only supportively managing the dyskinesias of Parkinson's, but actually possibly doing something on the progression of the neurodegenerative disorder. Finally, the other half of Parkinson's disease is to combat the excessive acetylcholine activity on muscarinic receptors. Let's remember that this is pretty important to do to decrease the resting tremor and the cogwheel rigidity that are observed in Parkinson's patients. They really don't have too much effect on bradykinesia, which is primarily due to the lack of dopamine in the first place. Amongst the drugs that decrease acetylcholine function are the atropine-like drugs, antimuscarinics such as benztropine and trihexyphenidyl were already mentioned in the autonomic nervous system section on atropine. So really what we've added here is diphenhydramine. Diphenhydramine is indeed an antihistamine, and we are certainly not planning on imagining that Parkinson's is a kind of allergy of any kind. It is rather actually to remind ourselves that pretty much all antihistamines are strong antimuscarinic drugs. They are atropine-like. Diphenhydramine has this point of being also available IV. And in hospital, when we have acute Parkinson type of condition, IV diphenhydramine might be used. To tell you the truth, an acute Parkinsonism is probably more likely with our next section, the drugs that block dopamine receptors, the drugs that we use to treat psychosis. So more to come on this. The side effects of drugs that are antimuscarinic are, of course, atropine-like. So you know what it means to secretions, don't you? It means you drying out those secretions. What is a classic complaint of people who take antimuscarinic? I'm sure you're telling me dry mouth. Dry mouth is very classically associated with muscarinic antagonism. Otherwise, at the level of the eye, what should I see? Mydriasis or meiosis? Yeah, they both start with M, don't they? Well, mydriasis is dilated pupil, and that's certainly a classic effect of atropine, together with blurred vision. What was the muscle involved in blurred vision? Ciliary, sphincter, or radial? It was the ciliary muscle blockade that resulted in lack of accommodation. And blurred vision is simply the fact that you cannot accommodate for near vision. Now, besides this, constipation, urinary retention, these are classic issues right there. And if you think of these peripheral issues, well, you have here two little stories that you may want to think of when you deal with older patients. What if the patient had glaucoma? Would these drugs be very safe? Let's never forget that antimuscarinic can precipitate an acute attack of narrow-angle glaucoma. How about if it was an older male? Urinary retention. What if that male had significant BPH? We don't like drugs that cause urinary retentions because with urinary stasis, we favor further the complication of urinary retention, which is at the very least the potential for cystitis, and worst case scenario, the issue of ascending the ureters into your kidney and causing pyelonephritis. Now, maybe more worrisome, atropine-like with this cyclamine is indeed
You can call me whatever you want, call me crazy. I wonder this push up on high. Keep on the job. We're gonna get this in now. You can call me whatever you want, call me crazy. They can call me whatever they want, call me crazy. I don't care. You can call me whatever you want, just call me crazy. Cannot do that. I don't care. Say no more. You can call me whatever you want. Still the episode ever. You can call me whatever you want, so call me crazy. Call me crazy. So I think I guess no. 한번 번지잖아.
Next is Chapter 21 and Central Nervous System Pathology. Now, the first thing we'll talk about are infections. Now, you see here acute meningitis. It can be viral. Of course, we'll talk about how bacteria are very important in causing meningitis as well. Very important is the secondary to viruses, that enteroviruses are typically the most frequent type. And of course, because it is viruses, you're going to see a lot of what? Lymphocytes. Remember, lymphocytes attack viruses, just like neutrophils attack bacteria, eosinophils attack parasites, right? Very good. So these patients are going to have fever, signs of meningeal irritation, and of course, depressed consciousness. Okay? Now, very important, if it's very good. So these patients Patients are going to have fever, signs of meningeal irritation, and of course, depressed consciousness. Okay. Now, very important, if it's acute purulent meningitis, okay, very important, again, secondary to bacteria. Of course, now you're going to see a lot of neutrophils. Now, remember, very important, if it's neutrophils, you're going to see exudate, right? So we're going to see that in the CSF. You also can see it on the meningeal surface grossly as well, okay? Now, very important, you see here, opaque leptomeninges. Again, sometimes I describe it as cloudy in appearance, so be aware of that. Very important, may be associated with fatal herniations. Of course, very important as far as manifestations. Again, cloudy sensoriums, it may have altered mental status, not really be with it, can lead to coma and death. Now, like I said, very important, you're going to get this purulent exudate. And typically, if it is bacterial meningitis, the exudate is going to be found on the surface of the cerebral cortex. That's the region of the brain you typically will see the cloudiness. Okay? Here's a picture showing you again, this is the brain here, and all this area here showing you cloudy exudate of meningitis in this region of the brain. Okay? So it's very important that typically see it over the cerebral cortex, and we're going to compare that to where you typically see it with tuberculosis. Here it is microscopically showing you Streptococcus. Again, you can see the organisms here. Okay. Here we go again, showing you Neisseria meningitis, typical diplococci that you typically will see. Okay. Very good. Now, like I said, with Mycobacterium, very important that if you see it, it typically involves the base of the brain. So the exudate will be seen in the base of the brain as opposed to with bacterial meningitis, again, cerebral cortex. That's very important to remember. Also, don't forget that because of AIDS, that there's an increased incidence of this, particularly caused by Mycobacterium avium intercellulare, which happens to be the most common systemic infection associated with AIDS patients. So that's very important to remember for the step exam. Now, very important, now we compare and contrast what we typically see as far as the parameters when we examine the CSF with the different types of meningitis. Okay? Now, typically, very important, if it's purulent meningitis secondary to bacteria, remember, bacteria have a sweet tooth, okay? They love sweets. So, number one, look at the glucose. It's going to be decreased, okay? Again, because of bacteria, neutrophils will be elevated. So, that's very important to remember, okay? Because, again, neutrophils attack bacteria. Protein is increased. Why? Because, remember, you're going to have an exudate. Remember, exudate has increase in protein as opposed to your transudate when we talk about edema fluid. So, very important. Low glucose, high protein, again, and increase in neutrophils. Now, you see here the pressure can become markedly elevated. And like I said before, this can lead to herniation. Very important complication associated with these patients. If it's viral, of course, it's mainly going to be lymphocytes. Look at the glucose level. Typically going to be normal because viruses, they don't like sweets that much. They're trying to watch their weight, whatever, I guess. So the point is, they won't do that. But you will get some increase in the protein, as you see, but only slightly elevated pressure. Okay? Now, moving on to your encephalitis. It's very important. When we say encephalitis, now we're talking about inflammation of the brain matter, okay? Brain tissue. And typically it's caused by viruses, okay? So very important, you differentiate meningitis from encephalitis. So very important, encephalitis typically caused by viruses, and because of that, you see these so-called perivascular cuffs, Microglial nodules, remember the microglial cells are the macrophages of the brain, so very important that you get these nodules, and you also get this neuron loss. Okay, now you see here as far as your clinical manifestations, mental status problems, fever because of the virus infection, okay, headache, and also may get coma if it does progress. Now, you see here different types or forms of encephalitis. The ones I point out real quick are going to be your herpes simplex virus type 1, typically seen in children, involves the temporal lobes. They may become hemorrhagic, and patients may have a history of behavioral problems, acting up in school, or the parents will tell you that they aren't, for some reason they're more aggressive or whatever. So that's going to be the key for herpes. And also you may see the so-called Cowdrey bodies microscopically, small little round eosinophilic inclusion bodies in the cells. Okay? Rabies, of course, the key is going to be somebody either hiking or camping, getting bitten by like a skunk or a bat in a cave or a raccoon or an opossum, that kind of thing. Because they know it can be caused by or transmitted by a dog. So they're going to give you something else. Like I said, either a skunk or a bat or a fox or a possum or some type of animal like that, giving you that. And you typically see microscopically the so-called Negri bodies seen in the cytoplasm, particularly in the your Purkinje fibers. Okay? And of course, HIV can be associated with encephalopathy, again, altered mental status, they get the so-called age dementia complex. And the key thing microscopically is you do a biopsy, you're going to see multinucleated giant cells. That's the key. Multinucleated giant cells microscopically for HIV. And of course, PML, again, which is related to or associated with HIV, patients also will have the altered mental status and that kind of thing too. Okay. Now, as far as your fungal infection, very important that you can see here Candida, Aspergillosis, Cryptococcus, Mucor are your frequent agents. Cryptococcus, probably the most common one, typically seen in AIDS patients, very important. Remember, that's the one for micro you get from pigeon dropping. So if somebody works in an office building or likes to feed pigeons in the park, it's going to be a classic presentation for that. For Mucor, you see here, as well as Aspergillus, they like vessels. But classically, remember, Mucor, broad base and typically seen in diabetics. Classic for the step, right? Broad base, hyphae, and typically associated with diabetes and vasculitis. Now, like I said, very important, Cryptococcus.
Break. I'll take a break. 10 minutes break. You can call me whatever you want. Call me crazy. insectida. Kurang aja. Dan mega kulon kecil. Nah, you can call me whatever you want. Call me crazy. Malabasyan. Ko. Bulbos ano no? Hindi to bulbos. Ito siya mo. Yes. You can call me whatever you want. Call me crazy. I don't care. I don't care. You can call me whatever you want. Call me crazy. One song I didn't look at. Kesini, tapi kesini, tapi pokoknya kalau boleh, medical minor non-invasive, senior senior. Coronizal stools, I don't know why this. Asalnya itu kan kuning mani asalnya kalau no, I don't care, I don't care. Wait, here I can go some more, yeah. I think I should open this. Now it is working fine. Okay, 126. I started this kind of like even Chitra could go like you understand me? Huh? You can call me whatever you want. Call me crazy. I don't care. प्लास्टिक पोली भनेको मलाई हात प्लास्टिक भयो इन्फ्लामेटरी भन्दा पनि हात प्लास्टिक भनेको त्यो डिटेच टर्न हो त्यो पर्थ्यो भयो नि द्याट इज मस्ट कज अफ प्लास्टिक रक्को भनेको यहाँ जस भयो त्यो हमारमा चाहिँ प्लास्टिक इन्भेन्ट्री सक्यो इन्भेन्ट्री भनेको चाहिँ युसी 99 एलिमेन्ट्समा टिबी लेस एउटा के अरे लेस ट्युबुलर मिक्स्ड हो ट्युबुलर भन्दा साइजमा हुन्छ बिलो सुरु भएर साइजमा ओके सेडेड गर्दाखेरि पर्दैनमा पोलिपसमा एफएफबी गार्डनर टर्कोड हुन्छ गार्डनर भनेको लिन्च सिन्ड्रोम पनि हुनु पऱ्यो प्लस ओस्टियोमास यस सबट्युमर हुनु पऱ्यो टर्कोडमा मिडल बास्टमा प्लस लिन्च सिन्ड्रोम सरी दापट्टि हो नि ट्रिकट आवाज आइरहेको छ मेरो आइरहेछ you should listen to me सुरुमा ए पिसी त्यसपछि केरियास त्यसपछि TP53 normal coronary correction adenoma colorectal cancer right side or left side right side भनेको क्लाउडी फ्लावर लेफ्ट साइड मात्रै त्यो न्यापकिन रिङ हुन्छ पेन्सिल स्टुल आउँछ तपाईँले आइरन डेफिसियन्सी एनिमिया हुन्छ अनि अर्को त्यो लेफ्टमा एप्पल कोरिलेजन भयो होइन पेन्सिल स्टुल भयो हुन्छ सिम्पल द्याट्स ऑल लिन्च सिन्ड्रोम MLS MSH HNPCC endometrial हुन्छ ovarian दुवै but not cervical they just related to SPV डिप्लो पढ्न मन छ cirrhosis prolar hypertension tips यो फोटो बिहान सन्टो यो धेरै झुकिन्छ यसको कममा increased due to estrogen how polar hypertension is increased due to estrogen how होइन fuck ए यो रिप्रोडक्टिभ भन्ने होला एस्ट्रोजन नै बढ्छ किन बढ्छ दोस्त किन बढ्छ एस्ट्रोजन लिभर डिजिज एन्ड एस्ट्रोजनसँग फेरि लिभरले बनाउँछ भने कम हुनु पऱ्यो होइन You can call me whatever you want. Quasi भयो के छ बुझ्नु गाह्रो इम्पेयर्ड एस्ट्रोजन मेटाबोलिजम त हुँदो रहेछ होइन पाउनु एथेन सर्च हान्ने मलाई होइन अरू पढ्न मन लाग्यो यही पढौँ जे पढ्नु लाग्छ त्यो पढ्ने हो estrogen and serotonin. Okay, estrogen A and D serotonin. Estradiol, estriol तीनटा फर्म हुन्छ एस्ट्रोजनको एस्ट्रोन र एडिपिट्युसले बनाउँछ एस्ट्रोन एडिपिट्युसले हो 1 ए प्लासेन्टाले एस्ट्राडायल नम्बर भयो नि हो जस्तै एडिपिट्युससँग रिलेसन छ अब हैन है nice I'm getting the function of the organ examine damage metabolism nice catabolism effect गरे भने एस्ट्रोजनले 25 minutes to go. मेरो र्याङ्क भनेको त्यसलाई के भन्छ फ्लाइन्ट I don't know that equivalent प्राइमेरी ब्रेड कोलाइटिस प्राइमेरी ब्रेड सिरोसिस हो खासमा यो होइन PSC सिरोसिस भन्थ्यो तर यो सिरोसिस हुँदैन यसमा मिसलेडिङ टर्म यसमा बोथ यसमा इन्ट्राहेपाटिक मात्र यसमा एनका माथि युसिसमा बोथ हुन्छ माइटोकन्ड्रिया एन्टिबडी हुन्छ होइन Oh no. Dun, dun, टोड के भन्छ टोडवाला फिमेल टोड केमा छ कहीँ न कहीँ त छ फिमेल टोडवाला फिमेल केमा छ बारोटर सिन्ड्रोममा किन मेटाबोलिक एसिडोसिस हुन्छ भन्दाखेरि चाहिँ लिपोप्रोटिनिक एन्टिसिसिन एड गर्छ त्यसको कारण सबै आयनहरू ब्लक भयो एब्जर्ब हुन पाएन सबै आयन गयो नन पोजिटिभ पोटेन्सियल सबै आयन गयो आइपो क्याल्सियम हाइपर क्याल्सियम नेक्स्ट हुन्छ किन हुन्छ भन्दाखेरि चाहिँ so the reversal because it needs to maintain smaller so that's a compensatory addition by must hypothetical numbers of adenine potassium still 18 minutes to go. Bagels. Fanikun. Bagels. Butter. Guitar man. Little insulin. secondary adrenal insufficiency and hyperkalemia भयो secondary adrenal insufficiency मा पिटरले काम गर्यो भने पिटरले काम गरेपछि के हुन्छ कोलेस्ट्रोल निस्कियो कोलेस्ट्रोल निस्किएपछि के हुन्छ हाइपरकालेमिया हुनु पर्ने हाइपरकालेमिया हुनु पर्ने हाइपरकालेमिया हुनु पर्ने किन हुँदैन भन्दाखेरि कोलेस्ट्रोलमा रेडी गर्ने रिङ एउटा रिङमै फरक पर्छ भन्दाखेरि Okay. Not a big deal. What a philosopher. के भन्छ चाहिँ पाति लेखेको छु इङ्ग्लिसमा प्रोक्सिमल टाइप ओके अन्डरस्ट्यान्ड होइन त्यही पनि अन्डरस्ट्यान्ड गरेर जस्तो गरिदिन्छु एसिडोसिस एसिडेमिया ओके नाइस आरपिसी कास्ट भनेको युनिफाइटिकमा हुन्छ डब्ल्युबिसी कास्ट भनेको पस पस भन्ने बित्तिकै पस एटिएम ग्यानर भन्ने बित्तिकै उसमा डब्ल्युबिसी पाइनेफ्राइटिस ग्यानर कास्ट भनेको एटिएममा हुन्छ फ्याटी कास्ट भनेको नेफ्रोटिकमा हुन्छ व्याक्सी भनेको एसएलई पायो भने सिकेडीमा हुन्छ अहिले त नम्बरले भइहाल्यो नेफ्रोटिक निगेटिभ टिएम नम्बर पाउनु भयो output symptom is always related deafness and eye problems. That's type 3 भने immune complex type 2 भनेको antibody deafness good posture syndrome type 2 type 3 भने SPGM wild dang fibrin plasma protein parietal cells पनि हुन्छ components capsule in the percent lumpy dang pH type 1 मा बेसी हुन्छ त्यसो पनि डेभलपमेन्ट कसरी गर्ने हो एक्युट र क्रोनिक पार्लिपाइटिस भनेको थाइरोइडाइजेसन एक्युटमा प्यापिलरी नेक्रोसिस मेन चाहिँ एउटा हो कम्प्लिकेसन्स हो देखिने न्युरोपिलहरू पनि देखिने प्यापिलरी नेक्रोसिस पेनिक एक्सेस क्रोनिकमा के हुन्छ त ब्लन्ट क्यालिक्स They can part of me for love. Maintenance 느낌 오죠. 아니면 고기 아워요. 또 문보는 느낌 오죠. Come on, sir. Come on, sir. Don't waste time. Let's see. Play. Print this. Will be off with this. Right. Trachomatis. Gonorrhea. Yummy. Colon. CMS. Colon. Listen to this, pomodoro non-computer. Pomodoro is so awesome. That means all negative. Okay, but yes, it will. Non-computer. Which one also? That will go with. We could run it. I'm wrong here. I'm wrong here. BRC2 हुन्छ यो this is 1 yeah I'm wrong yes BRC2 leads to HER positive ER positive HER negative right so this is BRC2 this is 2 non-commando TP papillary भनेको TP53 TP53 अच्छा positive nice 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 total cosmology भनेको number of papillary adenoma lead adenoma that's all papillary adenoma also pegatoid cells like in schools. You can call me whatever you want. You can call me crazy. That's me, guys. That's me. Most pregnancy. Hemolysis. Irregular enzymes. The platelets. What does it mean? What does it mean? 57, yeah, partial. 57. Egg and sperm. Egg and sperm. So that's it. That. Texas. What is that? Even perfect. Don't make a plan. Planning is important. I said randomly put the Q in, but that's when birth, you know. Permission plan on person. 1.5 times day. Body, Jacob body. Jacob dumb body that's correct. The body not okay. Body. भक्ति पनि गर्नुभयो प्रसन्न सबै perfusions are body parts more धेरै किन प्लाज्मा धेरै आएपछि अलिक कम त्यही भएर एनिमिया इज नट एनिमिया what kind of anemia hypercoagulability okay सब बेसी छ प्लाज्मा बेसी सब बेसी everything disease cadmium Do you say go? Wow. Nice. So then so I don't want to say meditation. But I think I should break out slow. Right? Bye. But I'll improve day by day. It is not a one day thing, so I need time.